is the inherited neuropathies, and we're going to focus on some of the challenges in really running clinical trials and being trial ready in rare neuropathies. And then Brett is going to talk about an example that he's working with TRPV4 mutations. So here goes. Amazing. So thank you. And I guess I'm going to stay on thank you for a while. So again, I'm going to talk about the approaches to trials in ultra-rare neuropathies, and these are my disclosures. And just briefly to introduce the inherited neuropathies, which we loosely characterize as Charcot-Marie-Tooth disease. So there are currently over 100 different genes which are known to cause CMT. And the overall prevalence is thought to be about 1 in 2,500. So most of these fall into what we can call ultra-rare disease. And even for some of the more common ones, as I'll try to show you, there are subgroups there that fall into the same area. And a reason that being trial ready is important for us is that, like many of the neuromuscular diseases at this conference, we're really at a point where there are rational clinical therapies available to begin trying in patients. And this includes antisense oligonucleotides, RNAi, and also, particularly for the recessive forms of inherited neuropathies, there's a lot of work going on looking at gene replacement. So what are the issues that we have to deal with? Okay, so the first, in fitting with this topic, is prevalence. So the most common form of CMT, and I see my first typo there, is CMT1A, and that prevalence is thought to be about 1 in 5,000. So not really in the ultra-rare situation by itself. But then when you look at the other common subtypes, they start dropping off to about 1 in 30,000. And then when we get into some of the recessives, they're rare still. So again, different prevalences for different subtypes. And then the other issue is that there's different phenotypes. And let's see if I can get this. Now this is a challenge because I don't know if I can actually start this here. So it looks like so far so good, it's starting on its own. And this is just to show you an adult with CMT1A, which is a slowly progressive disease throughout a person's lifetime. So dealing with slow progression is one challenge. But then there are other patients. And can you get rid of the sound on this? I don't want to have a name, I'm sorry. And this young man we're going to have to lift to get into a motorized wheelchair. So again, some forms of CMT progress rapidly in childhood, and these are typically ultra-rare forms, and other forms are slowly progressive. So a challenge for us when we want to be clinically trial ready is to be able to measure meticulously how patients progress, and again, often with small groups of patients. So let's see. And one of the ways that we do is with clinical outcome assessments in which in which investigators are carefully trained and have to be certified to do these evaluations. And these are just some of the examples of clinical outcomes. And I'm just going to start with results from one looking at CMT1A, which, as I've mentioned, is probably the most common form of CMT. But when you want to get to be clinically trial ready, and I don't have the laser, so I'm going to try to describe this. When you want to be clinically trial ready for these, you have to pick populations of patients that are most likely to show change in trials. And on the top part of this figure, there's a red line which shows the progression rate over 2 years in the mildest forms of patients at baseline. And in that group, you can actually detect a significant change using what's called a standard response mean in 2 years. But if you start beginning with more severely affected patients, then you lose that significance. So even in the more common forms, when you start looking at particular subtypes to treat, then they sort of begin moving into that ultra-rare area. And even in this case, if you want to detect significant change, you're probably going to have a couple of years of a study with perhaps 200 patients in an arm to do a clinical outcome assessment trial with this as a major outcome measure. So to deal with this, we've been focusing in the field on developing other outcome measures that can perhaps be a little bit more sensitive and actually based on advice from the MDA to be more functional. And this includes the CMT pediatric scale, which is a functional scale looking at dexterity. It has, I think, 12 points to it, and it looks at balance, the ability to ambulate. And this is good for children from 4 up until 20. And we've extended that into adulthood with what's called the CMT functional outcome measure. And again, this is very similar to the CMT pediatric scale. And then finally, we have a clinical outcome measure for infants, which is the CMT infant scale, which looks at birth through 4 years of age. And I'll just show you some examples so you can see the type of things that get done in this assay. And this, to give credit where it's due, this is work developed by Josh Burns and his group in particular. And that's looking at gross motor function, and that's also looking at fine motor function. So again, a challenge has been to develop really careful clinical outcome measures, but these are still often slowly progressive diseases for many. And so we've had to work to develop biomarkers as well. And I'm just going to show you a little bit of the biomarker battery that we have in place. And these include biomarkers that show potentially responsiveness to treatment, to markers of pathogenesis, to target identification, and to measures of progression. And the most sensitive biomarker we found in multiple types of CMT is intramuscular fat accumulation, which progresses in CMT1A, a slowly progressive form of CMT. It progresses by a significant amount in 12 months. So it has the potential to be a surrogate biomarker. But as the FDA has told us, we have to be able to predict changes in the increased fat fraction, what they mean in terms of clinically significant, clinically meaningful clinical outcomes. We also have been able to use skin biopsies, looking at probes that detect molecules that are expressed only by myelinating Schwann cells, and we can use that to detect target engagements. We can look at plasma biomarkers that will measure neurofilament light, which has been shown to correlate with our clinical outcome severity, and also in animal models for CMT1A and other types, these levels have been shown to normalize with successful treatment. We've been able to identify specific proteins in plasma that look like they're subtype specific, such as TMPRSS5. And finally, we've been able to look at a number of microRNAs that look like they're elevated, and not only in CMT1A here, but in other types of CMT. So we have a battery of biomarkers. We have a battery of clinical outcome assessments. So the challenges are how to put those together in ultra-rare forms of CMT. And these are some of the discussion points that we're having as we go forward with this, because we're not going to be in a situation for these ultra-rare cases where we're going to be able to have a double-blinded study with 200 patients in an arm, and perhaps biomarkers like MRI can help us drop those numbers to a certain extent. But to us, this just points out the need to really do meticulous natural history control groups so that if necessary, those control groups can help serve as the control group for trials. And then we have the issue of considering whether we can use natural history data from patients as lead-ins for those patients to be involved in trials. And then, of course, as I talked about, if we can determined that these biomarkers can actually serve as surrogate markers for clinical outcome improvement that's significant for patients. And then also some subtypes of CMT are fortunate to have like specific characteristics that can perhaps serve as markers for trials. And it's in that regard that I'm going to stop here and introduce Brett, who's going to tell us his experience with patients with TRPV4 mutations. But I do want to just, go back one. If I can go back one just to try again. And just to acknowledge all the people who have been my colleagues in these efforts over the years. So thanks. And Brett. Seemed to work, so.
Any tricks?
Yeah, I think prayer works in pushing that button.
All right, I'll say my prayers. All right. Okay, so my turn to struggle with the pointer. So thanks for the introduction, Mike. And thanks for the introduction to speak here today about our work on TRPV4 neuromuscular disease and our efforts in trying to get to a clinical trial for these patients. Here we go. Already not having the same luck that Mike had. Ooh. Okay, so we refer to these conditions as TRPV4 neuromuscular disease, which is also sometimes referred to as TRPV4 neuropathy. And so this really includes a heterogeneous group of conditions that are dominantly inherited due to mutations in TRPV4. And patients can have either isolated motor weakness and motor symptoms or sensory motor dysfunction. And so there were, back in 2010, 3 papers that described these patients initially. So the first paper described a CMT type 2C phenotype with sensory and motor dysfunction. Now regretting my decision to do a lot of animation here. The second paper described the CMT2C phenotype along with what they called scapuloperoneal spinal muscular atrophy. And so that phenotype was a pure motor phenotype that had a lot of proximal weakness. And then a third paper described those 2 phenotypes along with what they called congenital distal SMA. And so this was a congenital onset form of pure motor dysfunction. And so we sort of think of these as all related and interrelated, and there may be some overlap, but there's these definite differences in phenotypic manifestations. Okay. So what is TRPV4? So it's a calcium permeable ion channel that's expressed at the cell surface. And what we know is that mutations that cause disease all cause a gain of ion channel function, so increased calcium influx leading to cytotoxicity. And so this really suggests that this may be something that can be intervened on with a small molecule. So TRPV4 neuromuscular disease has some other additional unique and defining features. So there's quite a bit of, how do I go back? There we go. Clinical heterogeneity. So more so than in other forms of hereditary neuromuscular disease. So this is shown quite dramatically in this mother and daughter that have the same mutation, the mother on the left and the daughter on the right, and you can obviously see that they have quite different degrees of severity of disease. Patients with TRPV4 mutations also frequently have skeletal involvement. This can be seen with other forms of CMT, but it's often more severe with TRPV4 mutations. Other features can include scapular winging, reflecting kind of proximal muscle weakness. And then one of the sort of defining features of this condition is, if I can get to it, vocal cord weakness and diaphragmatic weakness. And so if you can play the video, this is a video of a 3-year-old that has a really severe form of the disease. And she has intrastory stridor, so a loud noise with breathing in. And this reflects the breathing through a narrowed airway due to vocal cord weakness. So you can see she's using accessory respiratory muscles for breathing. And then the last part of the video, you'll see her vocal cords not moving at all. So they're the pearly white structures, should be opening with inspiration, but these are completely paralyzed. So this is a really common and debilitating feature of this condition. Okay. So to study, sorry, can we go back? We might want to restart this video. So to study this disease in more detail, Charlotte Sumner's lab developed knock-in mouse models of the disease. And so what you can see in this model is that this mouse, maybe we can play that again, has clear weakness of forelimb muscles in particular, also has head drop and difficulty ambulating. And this is quite a severe phenotype that comes on about 3 weeks of life. And within 48 hours, this progresses very rapidly and the mice uniformly die. And so it's a quite dramatic presentation. And what Jeremy Sullivan, who's really led these studies, has found is that this phenotype can be dramatically reversed by treatment with a TRPV4 antagonist. So this is a mouse that had a very similar phenotype as the last mouse that I showed, but 12 hours after treating with a TRPV4 antagonist, you can see recovery of motor function. And if these mice are continued to be treated, you have complete rescue of the lethality and complete rescue of the motor dysfunction. So a really dramatic effect to TRPV4 antagonism. And so what this really suggests is that this condition is potentially treatable with a small molecule antagonist. So to review some of the reasons we say that, so we know disease mutations cause a gain of ion channel function. In these preclinical models and in cell culture models, treatment with an antagonist is really effective. We also know that loss of function of TRPV4 is not associated with human disease. Really wish I hadn't done so much animation. So there's no loss of function mutations that are linked to human disease, and knockout mice really don't have any strong phenotypic manifestations. And there's also been use of a TRPV4 antagonist in unrelated clinical trials for different indications. And the antagonist didn't meet efficacy endpoints for those trials, but it was well tolerated and deemed to be safe. So we really think that inhibiting TRPV4 could be safe and effective for this patient population. So that really raises the question of what can we do to try to get to a clinical trial for these patients. So that's really been the focus of our work going forward. And so as Mike talked about, there's a number of barriers to a clinical trial in inherited neuropathy in general, and some of those are present in TRPV4, and then TRPV4 also presents some additional challenges. So it's a rare disease. It's quite heterogeneous in its clinical spectrum. We don't really understand the full phenotypic spectrum or the natural history at this point, and we don't have good biomarkers for disease severity and disease progression for choosing patients to include. So we're taking an approach, a three-part approach to try to address these different barriers. So we formed a TRPV4 patient registry through the Inherited Neuropathy Consortium, and we've also developed a TRPV4 patient-specific questionnaire to try to get at some of the unique features of the condition and really ask patients what their experience of having this disease is really like. And then last, we have started an effort to do a natural history study. Oops. So for the patient registry, we have now over 80 patients enrolled. And when we look at those patients, we see that as compared to the sort of prototypical CMT, CMT1A, there's a lot more proximal weakness in these patients. So they have weakness above the elbows and proximally in the legs to a much higher extent than in CMT1A. If we ask about sensory symptoms, patients say that they, for the most part, don't have sensory involvement, but if we do detailed sensory testing, we do see clinical evidence of sensory dysfunction with vibratory testing, for example, in roughly a similar pattern as with CMT1A. So TRPV4 seems to be somewhat unique, has unique clinical features, and seems to be more of a non-length dependent disease, so more of a sensory motor neuronopathy rather than a typical axonal neuropathy. So moving on to the questionnaire that we've developed. So this was really designed to get at a number of different features of this condition. So disease onset, when symptoms started, when they were diagnosed, and then sort of typical symptoms of the condition. So I mentioned vocal cord weakness, respiratory abnormalities, proximal weakness, and then really asking patients how those things are changing over time. And then we're also looking for some unusual disease manifestations or perhaps some undetected, unknown disease manifestations. So we know that TRPV4 is expressed in bladder, so do patients have any bladder dysfunction? We know it's also expressed in skin, and there's been some reports of skin involvement in patients, so we're trying to see whether those are frequent occurrences. And then, importantly, we're also asking about quality of life measures and what really matters to patients. So what's the most important symptoms that they identify, what really bothers them, what impacts their daily life. So if we look at the data we have so far from the questionnaire, We see this sort of interesting pattern of age of onset. It's sort of a bimodal pattern with a number of patients, over half, having congenital onset in the first couple of years of life, and then a second smaller peak around 30 to 50 years of age. If we look at vocal cord and breathing symptoms, we see that pretty high burden of disease by patient report. More than half of patients have been diagnosed with vocal cord weakness, have shortness of breath. And then on the more severe end of the spectrum, you see about 10% of patients have severe enough vocal cord or respiratory abnormalities to require a ventilator or have undergone a tracheostomy. And then I mentioned also that there's a high burden of skeletal disease. So over half of patients have been diagnosed with scoliosis. Some have quite severe deformities with arthrogryposis, and then a more recently appreciated abnormality is tethered spinal cord. Oops. And if we look at other measures, so if we look at upper extremity strength, patients report really weakness distally and proximally, and difficulties with kind of proximal upper extremity function, and as well as hand dexterity function. And then pretty significant weakness in the lower extremities as well, with difficulty with ambulation, walking, hiking, etc. In contrast, we see there's not a lot of burden of disease in terms of pain. So some patients report pain, but it definitely seems to be much more of a motor predominant condition. In terms of what patients are most bothered by, we see really two main categories. So problems with strength, whether it's the arms or the legs, or manifesting with ambulation difficulties, over a third of patients. And then breathing and respiratory symptoms come in as another really important aspect of the condition. So the weakness and the respiratory difficulties really seem to be driving disease for patients. If we ask the question a little bit in a different way, what's the greatest impact on your daily life? What symptom? This is really dominated by motor weakness, whether it's the hands, arms, legs, or difficulties with walking. So the patient questionnaire data has informed now our development of a TRPV4 natural history study. And so this is now going to be set up through Johns Hopkins, and this is quite fortunate to have funding through the MDA, as well as Actio Biosciences, which is a biotech startup company. And so with this support, we're able to actually pay for travel, lodging, and all testing expenses for patients. So this is going to be free of charge for them. And it's going to be quite a battery of testing to be performed over 2 days. And our hope is to do this yearly and over 6 years. And it's going to be a really multidisciplinary evaluation, obviously with neuromuscular evaluation, but also ENT, orthopedics, given the skeletal involvement. And then we're also looking at a number of potential other assessments that can hopefully yield biomarkers for a clinical trial. So I'll go through some of these in a little more detail. If I can get this to advance. Whoops. Okay. So the neuromuscular evaluation, Dr. Shai covered quite nicely. So this will include some of the CMT scoring systems that he described, CMT functional outcome measure. We're also going to look at respiratory function and perform EMGs. And I think a really important component of our evaluation is going to be ENT evaluation, given the vocal cord abnormalities. So all patients will undergo quantitative speech and dysphonia analysis, and they'll also undergo video laryngoscopy. And so you can see on the bottom is an example of a control patient with normal abduction of vocal cords. So the angle increases as the vocal cords open, whereas a patient with TRPV4 mutation has partial weakness of vocal cord abduction. You can see the angle is reduced. And so in collaboration with Actio, we've been looking at machine learning as a way to try to quantify vocal cord movement. So this is this Agati program is a now open source AI-based approach to look at vocal cord movement, and this has been able to demonstrate now reduced abduction and opening of vocal cords in TRPV4 patients. So we're hopeful that this will provide a nice quantitative measure that might be able to track the vocal cord abnormalities in this patient population. So additional testing will include orthopedics evaluation with a skeletal survey, a DEXA scan, And then based on some surprising observations in the knock-in mice, we're also doing retinal examination, looking particularly at retinal vasculature. So unpredictable. There we go. And another observation from the knock-in mice that was quite surprising is that they actually show blood-brain barrier disruption and spinal cord barrier disruption. And so we're very interested to see whether there may be similar disruptions in patients. And so to look for subtle blood-brain barrier dysfunction, a normal gadolinium-enhanced MRI is really not sufficient. But with a collaborator, Richard Lee, who's developed a specialized protocol called dynamic susceptibility contrast, we've been able to look at a few TRPV4 neuromuscular patients and see what looks like an early signature that might suggest that there is blood-brain barrier breakdown, and this needs to be further validated, but may prove to be a nice biomarker for these patients. Oops. And then lastly, we're looking at other biomarkers, sort of as Mike talked about, neurofilament light chain as a marker of neurodegeneration, and also urine markers for blood maturation, or for bone maturation and bone health. And then we're collecting also PBMCs as sort of an ex vivo assessment for gain of TRPV4 function and also the potential efficacy of small molecule inhibitors. So the goal of all of this really is to identify clinical outcome measures that reflect disease severity, disease progression, and help to choose patients that would be most likely to show a benefit in a clinical trial. And certainly we also want to tether those outcome measures to things that are important for patients. And based on the questionnaire, we think probably the things that really are impacting patient quality of life and function are measures related to hand function, gait difficulties, and certainly the respiratory involvement as well. So with that, I'd like to just acknowledge the people that help with this work. So we've really benefited from a very engaged and active TRPV4 patient community. There's a Facebook group that's run by Stephanie Carmody, who has a mutation herself, that has really helped to drive this research forward. Then a number of people in the Sumner lab have helped with the animal models, and then we have a really large clinical research group that's helping to evaluate these patients. So with that, we can take questions.